Hello and welcome everyone to our October MMS Info Session. These sessions are offered under the CMS Measures Management System contract, led by Battelle. I am Kate Buchanan and I support the education and outreach efforts of this project. Today's session is on population health measures, what they are and why they matter. You'll hear from my colleague Brenna, who will provide an overview as well as some nuances associated with population health measures. Can we go to the next slide? These info sessions are part of an ongoing effort to engage measure developers and other stakeholders in quality measurement topics, an effort that also includes a series of newsletters and bulletins, along with special announcements, emails, public webinars, and routine updates from the Measure Management System website. Before I turn it over to Brenna, I do want to cover a few housekeeping items. First, today's session is being recorded. Second, all participants will be muted during the call. We will have an opportunity for Q&A at the end of the call, during which we encourage you to answer your questions into the chat feature. I want to point out where the Q&A section is. So if you look on the right-hand side of your panel, you should see Q&A to click on. If you do not, on the bottom right, there are three dots that say panel options. If you hover over, from there you can select the Q&A panel. We encourage you to ask questions throughout. You do not have to wait till the Q&A period starts, and we will answer as many questions as we can with the time that we have. Finally, the presentation slides from today's session are posted on the MMS website. You can see that in the chat. We have links to both the slides for today as well as the population health supplemental material. The recording of today's presentation will be posted to the CMS YouTube page at a later date. And with that, I'm going to turn it over to Brenna.
Thank you, Kate. I thought in lieu of an agenda today, we could just do some level setting by sharing some objectives. Of course, we're aiming to help you understand what population health measures are and why they're important, as the title hinted. But as you'll soon see, it's a more complicated topic than it sounds, and we're going to dig into some of that today. We'll also talk a little bit about where the gaps are in terms of population health measures, along with some of the tools that exist that might help you, kind of get started identifying high-impact population health topics. And then finally, we'll talk about some of the key population health specific issues that factor into the different phases of measure development. So before we get into the measurement piece, let's just start with a quick conversation about population health more broadly. So population health, despite its name, does not refer to everyone. It's not synonymous with public health. Population health refers to overall health behaviors and outcomes of a broad but clearly defined group of individuals. And those outcomes should be measured with the characteristics of that population in mind. So for example, a population might be all Medicare beneficiaries 65 and older, or it could be defined more narrowly, like Medicaid and or Medicare beneficiaries with severe mental illness. When tracking outcomes for either of those populations, it's important to consider the unique characteristics that apply to them. So taking that a step further, population health measures are broadly applicable indicators that reflect the quality of a group's overall health and well-being. So you might be wondering, how is this different from any other quality measure? And the idea here is that population health measures, either alone or grouped together, should tell us something about the overall health status of the population it's measuring. So screening and outcome measures are especially useful for this, measures that give a sense for example, the percent of a population adhering to vaccination or screening guidance, or the percentage of patients that avoid complications due to diabetes, for example. On the other hand, measures that evaluate specific processes or those limited to certain clinical settings may not fit the bill to be considered population health measures. So for example, a measure that looks at the average time between arrival to the emergency department and a CT scan, might be an important measure of clinical quality, but it doesn't actually tell us anything about the health of any population. And so as such, we wouldn't consider something like that to be a population health measure. And before we move on from this slide, though, I just do want to note that it's important for people to know that population health measures and clinical quality measures are not mutually exclusive. So a measure that assesses population health outcomes can also be a great indicator of clinical quality, and therefore would fall into both categories. And the same goes for things like screenings, wellness visits, vaccination rates, and so on. So naturally, population health is dependent on a whole range of factors, not limited to what is measurable in a clinical setting. So we know there are links between environmental factors, things like air quality that impact rates and severity of diseases like asthma. We know that economic and social factors such as poverty or homelessness can drastically impact access to care and long-term health outcomes. We know that access to reliable transportation makes a big difference in terms of how well patients adhere to follow-up care guidance. So, to truly move the needle on broader population health issues, we need to take a multi-sector approach that kind of links the healthcare system with other community and private sector partners, as well as federal, state, tribal, and local governments. And that's a tall order and not easy to do from a measurement perspective. Most quality measures rely on data from claims or from electronic health records, which typically don't include information from those other entities. And that shouldn't discourage us. Population health measures that rely on clinical data can tell us a lot about the health of key populations and highlight areas where external factors like those listed on this slide come into play. So the goal with population health measurement is to think broadly about a given population and try to understand the extent to which they're engaging in good health behaviors and experiencing positive health outcomes. So having said all that, you're probably still wondering exactly how population health differs from public health, and there is overlap in these concepts for sure. For our purposes today and for the purposes of CMS quality work in general, population health can be viewed as a more narrow category than public health with a slightly different focus. Population health is mostly concerned with the health outcomes of a group of individuals, which, as I said before, can be defined very broadly or less so. These population health outcomes can absolutely be tied, at least in part, to the delivery of clinical care, but are also impacted by things like genetics, behaviors, environmental factors, and so on. The focus of public health is on protecting the health of entire populations and involves activities that extend well beyond the provision of medical care. Population health activities are focused on things like water sanitization, workplace safety, motor vehicle safety, infectious or chronic disease prevention and control, and so on. So while public health practitioners absolutely use metrics to evaluate the success of their interventions, they're not the types of metrics that fall under the direct purview of CMS and other payers, since the focus here is on the delivery of high-quality health care. So as such, our focus today is going to be on measures of population health that are based, at least in part, on healthcare data. And as you can imagine, population health is a fairly high priority in all levels of government. In their 2020 annual report to Congress, N2S Standing Committee on Prevention and Population Health highlighted 7 population measure gaps, so areas where there needs to be a little bit more work in terms of measurement. And they suggested efforts to bridge those gaps through the development of measures that focus on things like disparities and determinants and social determinants of health, things like adequate housing, employment, transportation, the care coordination across the lifespan, so being able to actually see the extent to which patients are getting the right treatment from all the different providers and clinical settings where they interact with the healthcare system across their life. Pediatric population and neurological conditions, consideration of how physical and occupational therapy perform as it relates to those neurological conditions. A big one here is under perinatal and women's health. A really interesting one listed here is under provider burnout. So this is interesting in that it addresses the health of the provider population and may even have implications for how effectively care is delivered to the patient population more broadly. And then finally, care integration between mental health, substance use disorders, and physical health. Physical health being encompassed by things like primary care. And in order to, better understand how effectively the healthcare system is treating and managing patients with mental illness, We need to promote and then measure the extent to which healthcare systems are effectively integrating mental and physical health care for their patients with needs in both areas. Just knowing how patients' conditions are when they're discharged from an inpatient psychiatric facility, for example, tells us very little about the overall health or quality of care for that population. We would also need to know the extent that those patients receive follow-up care in an ambulatory setting, or to what extent patients are adhering to their treatment plans to get a better sense of that. So you probably put together, based on that list of gap areas, that there really is no single population health measure that answers any of those needs. We have lots of measures that tell us a little something about the health of a given population, but really no one measure that tells us everything we would need to know about the health of that population. So take the example of perinatal health. It's hard to imagine a standalone quality measure that could adequately evaluate the overall health of pregnant women, let alone their babies. So to do that, you might consider, one of the approaches listed here. So first, aggregating health outcome measurements made on people into summary statistics, such as population averages or medians. And this is a solid approach if you have measures that are widely reported, such that you have sufficient data to do that. But my favorite of these approaches is to assess the distribution of individual health outcome measures, in a population and among specific population subgroups. So in other words, basically assessing performance on a handful of carefully selected perinatal measures that, when examined together, provide a more comprehensive picture of the health of that patient population. And then finally, and perhaps this goes without saying, it's important to be measuring the function and well-being of the population or society itself, as opposed to the health or well-being of individuals. Regardless of which of those approaches you take, the IOM offers criteria for selecting and prioritizing measures of quality for use in population health improvement. And that really is key. Population health measures should be actionable. They shouldn't just give us a status update on how folks are doing. They should be structured in a way that allows experts to make inferences about how improvements to care could actually improve outcomes for that population. So unsurprisingly, that means that measures should be timely. They should be accepted by the scientific community at large, understandable to relevant stakeholders. They should be based, using strong methodology, and of course, usable for assessing the health of a given population. And assuming that all of that is the case, then the conditions or outcomes being measured should also be reflective of, highly preventable burden and actionable at the appropriate level for intervention. And actionability is going to come up again and again here. Any effective population measure needs to yield information that can be used to drive further improvement. And then when we talk about reflecting highly preventable burden, we really just mean that the actionability needs to be within the control of the person being measured. It doesn't do us any favors to hold a provider accountable for improving the health of the population that they don't see, for example. So it needs to make sense. So as you think through potential measure concepts to assess population health, you'll need to keep all of this in mind. And as I've said a few times already, population health measures should identify opportunities for improvement at the population level. So these measures shouldn't just be focused on identifying gaps or variations in the delivery of clinical care. If you've developed quality measures before, you might be thinking that it would be difficult to create an effective business case for a population health measure, since most quality programs are geared towards creating incentives tied to improvements in care within specific care settings, and that's true. So it's important to think about where you anticipate implementing your measure from the outset. If you're developing a population measure for use in a CMS program, consider whether changes in clinical care might drive improvements in the population outcome you're measuring. If you can make that connection, then you're well on your way to conceptualizing your business case. So in the next couple of slides here, we're going to share what we're calling measure conceptualization tools, but I think maybe a better name for these are kind of places to get yourself started, right? How do we identify population health gaps, and how do we think about what's actually reasonably measurable? So starting with the idea of an environmental scan, to identify similar or related measures. It's a crucial part of any measure development effort, but it's important to note that for population health measures, developers may need to expand their environmental scan search criteria beyond their usual sources. So, for example, we typically look at the CMS measures inventory tool, that's CMIT, or the NQF quality positioning system to look for existing measures. But when thinking about population health measures, developers might need to look to CDC public health indicators or OECD indicators for population health and health system performance to identify gaps in population health measurement. We also recommend thinking about community health needs assessments. They are used to identify the health needs of a community served by a given hospital and help develop an implementation plan to address those needs. So ideally, you need metrics to determine if the implementation is successful. So developers of population health measures could use the identified needs and metrics as a starting point for development. You'll also need to look at the literature of measurement. Doing a more formal literature review could highlight important research related to things like social determinants of health or other risk factors that might impact the types of measures you pursue. And then finally, Healthy People 2020-2030 is a great resource that includes a set of broad population-level goals broken down into 5 categories. Those are health conditions, health behaviors, populations, settings and systems, social determinants of health. And so that's another place to start and just kind of see what's already out there and where the low-hanging fruit might be. So then if we move on from conceptualization and start thinking about the impacts on measure specification, the overall structure of population health measures is pretty much the same as for most clinical quality measures. But there are specific parts of the specification where you'll note some key differences. So obviously the target population is likely going to be much larger and more broadly defined than you see in a lot of quality measures. And in some cases, these might even be defined at the geographic level, although that's not a requirement for a measure to be considered a population health measure. Other parts of the specification where the population health measure information would be reflected are listed here, notably in terms of how the measure is stratified, which is absolutely crucial for a population health measure, the types of data sources used for obvious reasons. If you're relying on clinical or other non-clinical data, that's going to look a little bit different than it would for a measure that's entirely based on things like claims data. The level of analysis, risk adjustment as appropriate, and then even the time interval. How far back do you need to be looking at these populations in order to track improvements over time? All right, so moving on to measure testing. Measure testing, like all steps of the process, can be challenging because you need to evaluate reliability and validity of data elements from multiple data sources in a single measure. So you may encounter a lack of data, especially around things like social determinants, and measure developers are going to need to consider the completeness or incompleteness of data sources and then the required data elements early on when developing their testing plans. More generally, though, developers may also struggle with the concept of attribution. And attribution, for those who don't know, is really just who the measure is, who is sort of accountable for the measure. So for most clinical measures, this is pretty clear. Hospitals and physicians provide clinical care. Public health and social service agencies don't, or do so in a very limited capacity. But with the increased emphasis on the importance of social risk factors, healthcare systems are more directly involved in addressing some of these social risk concepts, through the direct provision of or referral to services like housing or food security, or they're formalizing collaborations with entities outside the healthcare system. So for the purposes of defining the quality constructs for measure testing, the measure developer may need to expand attribution for traditional measured entities to include the delivery of public health and social services, or to expand the measured entity to include both healthcare and non-healthcare providers. The more expansive the population in the denominator, the greater chance the developer is going to have to be creative with their testing plan, and maybe need to partner with a variety of stakeholders, including data owners, to understand the scope of their testing needs. a lot of this is fairly uncharted, so flexibility and innovation are going to be crucial to move towards success here. For considerations when testing measures, there are many, but we're highlighting kind of three here. The first being which system owns the quality construct. So this comes back to, sort of what I was talking about before related to attribution. So for the purposes of this conversation, the idea is that we need to do our best to think about who is ultimately responsible for driving improvements on the quality measure, and that is the entity that should be considered sort of responsible or be the measured entity, so to speak. And that may mean including more than one entity in that bank, which is going to require some creativity. And then once the developer defines that quality construct, then measure testing would proceed as with any quality measure, with a focus on importance, scientific acceptability, feasibility, and usability. We also have this concept of public good when we're talking about population health. So there really must be a sort of a person level, process outcome relationship established with rigorous evidence. And then there has to be entity level demonstration of validity, showing that there's alignment between the behavioral response of people and clinicians to the measure with the end user intent. Now that's a mouthful, but the idea is that you need to be able to demonstrate that changes either to patient behavior or changes in, let's say, clinical processes are actually going to drive improvements, drive improvements in the population's health in order to be sort of useful. And then the nature of the population level outcome, a population level outcome might examine the distribution of outcomes across population subgroups, and consider whether increasing access to healthcare or social services for certain subgroups would have the largest impact on outcomes. So are all population subgroups impacted the same way by access to a given, intervention? I think it's super important with a population level measure to stratify as many ways as you can do reasonably to understand, the level of uniformity of the impacts of your measure. So due to population health measures not being setting specific, their adoption would primarily be into CMS programs, such as the Medicare Shared Savings Program, the Market-Based Quality Rating System, Medicare Advantage Program, and potentially even NIPS. So the ideal plan is to use population health measures broadly, report them at the community level, and then share results among participating clinicians, public health, community, and other organizations. Population health measures are subject to the same three types of measure maintenance reviews as other types of measures. So, sort of annual updates, a triennial comprehensive review, and then early maintenance using the measure evaluation criteria that are outlined in the MMS blueprint. So that's just a long way of saying that basically population health measures follow the same overall life cycle as any other clinical quality measure. There are just, some unique considerations, especially during testing, that are specific to the broader population being defined. So with that, we do have some announcements, but I would like to just pause quickly here, see if there are any questions.
Great. Thank you so much, Brenna. And we have received several questions, but I do want to encourage more. So if you see on the right-hand side, there should be a Q&A panel. If you cannot find it, please click the three dots at the bottom right corner and open up the Q&A panel. We encourage you to ask your questions. So we have a couple to begin with. And one is, does CMS use population health measures?
Yeah, so that's a tricky question. But the answer to that is really depending on which sort of definition of population health you're using. And I say that because there are many. CMS has recently published a gap analysis around population health measures for MIPS. Suggesting that there are indeed such measures. And we can provide a link to that document in the chat if anybody is interested. But that said, there is currently no single measure that assesses the overall, health of a specific population. But there are lots of measures that potentially, when examined together or with other measures, can definitely give us a sense as to the overall health or quality of care for a given population. So what comes to mind are things like vaccination rates or adherence to medication protocols, attendance to wellness visits, things that tell us something about the overall, quality of care or health of a given population.
Wonderful. And we are getting in some more questions. The next one we have is, in addition to clinical data, what other data sources can be used to score population measures?
Yeah, that's another great question. I think right now I'll just kind of start by acknowledging that most of the measures that I've described that are currently in use are based entirely on clinical data. I don't want to oversell the prevalence of these measures, but there are some, I wouldn't say low-ish hanging fruit in terms of the kinds of other data sources that developers might consider moving into. I'm thinking specifically of like the PDMPs, right? The prescription drug monitoring systems, where you can access information about the drugs that are prescribed and filled for different individuals, agnostic to the specific pharmacy. I can see that being something that might be linked with clinical data to tell us something about population health. I also think some registries do a good job of collecting, social determinants of health information and other pieces of the puzzle that aren't necessarily prevalent in clinical data. So those are sort of my initial thoughts. But if others that are on the call today have other ideas, please feel free to enter those into the chat.
Great. And I did want to say that we are adding the environmental scan, the MIPS environmental scan, into the chat function so that people can have access to it. We received several questions about that. Looking through, it does not look like we have any other questions. Most of them are related to information on the population health supplemental material, link is in the chat, as well as the MIPS QPP environmental scan.
I did just see one that came through about recommendations on population health measures for oncology patients. And so I think the short answer is that I don't have necessarily recommendations on any measures that exist, although that isn't to say that there aren't any. But I think that's a great example when we talk about, population versus public health. I think that's a great example of a population that we would want to be focusing on, looking at how well oncology patients are sort of thriving and getting through the healthcare system. So I don't have a great answer to your question, but just want to acknowledge that that's sort of exactly the kind of scope that we're talking about here.
And great, thank you so much. We did just have another question about possibility of getting a recording the slide deck. The slide deck is in the chat. So it is also posted to the MMS website, and we are going to be posting a recording of this in about a week. So I think we can move on to the announcements.
Sounds great. And if anybody has any thoughts on additional questions between now and when we wrap, you can still throw those in there. But we wanted to note that in case you missed it, our September info session, which was on overcoming common challenges in the measure development lifecycle, is now available on YouTube. So if you guys join us for our info session in November, there will be an announcement at the end of that slide deck saying that today's presentation is available on YouTube. So we encourage you to attend that. The next info session that we're doing on the 17th from 2 to 3 p.m. Eastern is a review of what's new in version 17 of the MMS Blueprint. So as a little teaser for that, I think most folks that are on the line today know that, the MMS blueprint is, sort of the definitive source for information on best practices and guidance for developing quality measures, specifically for CMS programs, but really for any program. And we update that document every single year based on stakeholder input and emerging guidelines in the literature. So it's definitely worthwhile to join that call to find out, what's changed in the blueprint so that you know what the latest is in terms of guidance. All right, I did see we got a question about the 2020 gap analysis. We can certainly send around to all participants the link to the one that was done by another CMS contractor but that gap analysis is specific to MIPS, unless you were talking about the NQS gap analysis, in which case I believe the one that we cited in the presentation is the most recent one. And I am not seeing any other questions coming through, so I don't want to hold anybody longer than necessary. So I really appreciate everyone's participation today and the thoughtful questions that came through. If there are any other documents or resources that we can send your way, or if you have any questions that you think of after we part for the day, you can always reach out to us, either to me directly at rachel@battelle.org, or truthfully, if you want to get a quicker response, then reach out to our support help desk, mmssupport@battelle.org, and we'll put a ticket in and get you what you need. So thank you all very much, and we will talk to you again in November.